Welcome to another edition of our Facebook Focus. My name is Husnain Kermalli. I'm the Chief Medical Officer here at St. Mary's Hospital in Waterbury, Connecticut. Each month we like to highlight certain services and service lines that we're able to offer to the community here in Waterbury, Connecticut through St. Mary's Hospital and Trinity Health of New England, and really showed to the community what expertise and services that we can participate in and offer through our medical group and to the community. So this month, I'm really excited to feature our entire, well, not really our entire, but a portion of our gastroenterology department. And so today with me, I've got Dr. Uday Shankar, Dr. Praneet Wander, and Dr. Russell Parvin, three of our gastroenterologists that make up our GI department. So thank you very much for taking time out of your busy schedules to meet with us today.
Thank you.
So let's talk about the GI department here at St. Mary's Hospital. In addition to you three, we've got a pretty large department and it's growing. So tell us a little bit more about it.
Yeah, we're a team of 5 GI physicians now, and there's another one joining us, Dr. Patel, who will be joining us in June, so in a couple of months.
Make 6.
Making 6.
6.
We have a good support of mid-level providers as well, 4 PA and NPs, and another mid-level provider joining us soon as well.
Yeah.
So we're a growing department. I'm extremely proud of this team. You know, we've really developed so much over the last couple of years, from really sending out our most advanced cases to really now the other way, where we are a referral center, we're a high volume center, and really able to provide the gamut of gastrointestinal needs for our patients and community.
Yeah, I mean, it's, and when we say 6 GI providers plus your PAs, I mean, you're able to open access to patients whenever they need a GI specialist.
Yeah, absolutely, and that comes because of the seamless way we work together with each other, as well as related departments like surgical department, IR, both whom we work very closely together. We share patients, communicate very regularly. So if there's one patient who would be better suited for certain services that one of us provide more commonly than another one, or more specifically, we very easily can refer back and forth.
Great,
so that
great.
Works out very well.
So with you three sitting here, tell us a little bit about each of you and your specialties.
Yes, I started here in 2017
Yeah.
after pretty much finishing up training. I did medical school at SUNY Downstate in Brooklyn. Went over to Robert Wood Johnson program in New Brunswick.
Okay.
And then came back to Brooklyn Hospital for GI fellowship. I actually also did a year of hepatology, and then finishing all of that, came over to here in Connecticut.
So hepatology liver specialty.
A non-transplant liver fellowship.
Non-transplant liver fellowship. Yes. Wonderful, wonderful. Dr. Wander.
I'm Praneet Wander. So I did most of my medical school training back in India.
Okay.
I moved here for residency. I trained at St. Luke's Roosevelt, Mount Sinai in Manhattan.
Okay.
I did my GI fellowship at North Shore LIJ in Queens, Long Island. And then I did a 4th year in advanced endoscopy, learning EUS, ERCPs, luminal stenting, all advanced endoscopic procedures.
Okay.
And then I moved here to Connecticut.
And you are an advanced endoscopist, if I'm not mistaken.
Yep, that just means we do more therapeutic endoscopic procedures. Instead of just diagnostic, we can do a lot of things endoscopically, and the hope is that we do procedures where we can avoid or at least decrease the amount of surgical intervention that patients are getting. So it's minimally invasive surgery.
Okay.
Where we work with surgeons or IR physicians and other members of the team to try to see the best approach for the patient so that we can avoid extensive surgeries for them.
Very nice, very nice. Dr. Shankar.
Yes, I'm Uday Shankar. I did my medical school in India and then moved here for training in internal medicine. That was at ICANN School of Medicine at Queen's Hospital. And then I did my GI fellowship, the same place, ICANN School of Medicine at Elmhurst Hospital.
Okay.
I joined St. Mary's in 2019, and since then it's been a pretty good experience here. I do almost all the GI procedures, the basic diagnostic endoscopies, colonoscopy, and I also do ERCPs and recently started doing endoscopic ultrasound as well. And I do part of a little bit of therapeutic endoscopy, what Dr. Wander was mentioning
Yes.
as well.
So a little bit of advanced endoscopy on your slate as well.
Yes.
Yeah. So it's really exciting because I think the therapeutics that we're able to offer as well in our department are pretty extensive. So let's talk about some of those common as well as more complex procedures that our department is able to offer.
So I think our department offers pretty much most of the GI procedures, starting from upper endoscopies, colonoscopies to endoscopic ultrasounds, ERCP procedures, anything that requires intervention in the bile duct, including spyglass. We do offer procedures for heartburn acid reflux like TIF. We take care of most of the complicated polyps, whether they're in the colon or in the stomach. We're also now doing manometries, which are diagnostic tests for heartburn and acid reflux. So I think in the realm of GI procedures, we offer pretty much everything here.
So you talked about a couple of very specialized, well, to me, specialized. I'm just an internal medicine doctor, so you'll excuse me when I say very specialized. But spyglass and TIF, explain those to me, because I know at least for TIF, that's something relatively new that St. Mary's is able to offer, and different because it's definitely outside of the normal surgical approach that would be taken.
Yeah.
Yes.
Yeah.
This is not a very new addition to treatment of gastroesophageal reflux disease, but now lately a lot of centers, a lot of places have started offering it because of the excellent results we are seeing. So TIF is basically transoral incisionless fundoplication. Is creating a valve at the lower end of the esophagus around the stomach to prevent reflux. And with this, patients can get off of the medications to reduce the acid, commonly known as these PPIs.
Okay.
So lately we have noticed a lot of side effects with PPIs.
Yes.
And that's what we have been offering here. Sometimes this procedure is done with surgery, and we call it concomitant TIF. And sometimes patients may just need only TIF. So we're really excited about Dr. Parvin and I do this procedure, and we're very excited that we are able to offer this to our patients.
Well, I mean, it's just another one of those patient satisfiers where we're putting the patient first. I mean, when we think about medications, when I think about medications and how the interaction, the polypharmacies, the pill burden sometimes with the handful of pills that patients get prescribed ultimately, one for this, one for that, one for the other, and then we talk about side effects of medications and PPI, which we think, oh, it's just a PPI, but it does have side effects, and some of them can be pretty significant when we think about C. diff even as a side effect of PPI, and that can be disastrous for some patients.
Especially these patients are on these medications for a long time.
Yeah.
And younger patients who are in their 30s or 40s, they have a long life. Longer you are on PPIs, more chances of having the adverse effects.
Yeah.
So this is something worth considering.
Yeah, I mean, it's just another great advancement in the treatment of GERD. When PPIs came on board, it was a huge advancement from the prior medications. They were a lot more effective, and a lot more patients were able to get relief from not only their symptoms, but a lot of the organic disease that comes from the GERD, precancerous conditions like Barrett's, strictures, ulcers, esophagitis. And so TIF is sort of a modification from more traditional maneuvers like the Nissen fundoplication, a surgical approach, but TIF provides similar efficacious outcomes with fewer side effects and less severe side effects. With the traditional fundifications, a lot of times people can be able to belch or vomit or would have dysphagia, and those are a lot better.
Okay.
And compared to medications, it is a more direct treatment of reflux because you're really augmenting the barrier between the stomach where the acid is supposed to remain and the esophagus where it's not supposed to come up, but it does very commonly, as opposed to medication that shut down the acid secretion mechanisms, which if you do that can really have other effects, and that's part of why we get some of the side effects.
Yeah. No, it's remarkable, and it's great that we're able to offer something like this here to our community in Waterbury.
But I do want to mention that some patients do require PPIs.
Yeah.
Despite the small amount of side effects that they could have. There are certain conditions in the GI world where PPI are warranted.
Of course.
And patients have to take them because it does, decrease the chances of esophageal cancer in patients with precancer conditions from chronic acid reflux. So I don't think it's a complete replacement for PPI. I think some patients still require PPIs. I think it's an adjunctive therapy for patients who are candidates for this procedure.
That's
Absolutely,
a great
yeah.
point. That's a great point because, like Dr. Warner is mentioning, some patients may have a precancerous condition called Barrett's esophagus. Even if they go for this procedure, it may reduce the amount of acid reflux they're having, but they would still need the medication.
Yeah.
You're bringing up a great point, because when does a person need to see a GI doctor, right? So they're coming to an internal medicine doctor, they come to see their primary care doctor. Doctor, I've got GERD. Okay, we're going to start you on therapy. There's this first step. There's a second step. There's maybe even a third step. But when is the step when the patient says or the physician says, hey, I really believe you need to go see a GI doctor? And then what are some of the common conditions that a patient, they're going to need to see you guys regardless of anything else? They're coming to see one of you, right? And there's a point I'm going to come see one of you too soon as well, and we're going to get to that. But what are some of the other common conditions? GERD is one of those pieces where maybe their primary care physician can take care of them, but then maybe it progresses to something else where they do need to see a GI doctor. Let's talk about a little bit of that.
So,
Go ahead.
no, you got
Well, part of that is that we are a procedural field, right? And that's one thing we specifically have trained in. And so that is an obvious reason why you would need a gastroenterologist for the upper endoscopies, the colonoscopies, the ERCPs, and the other modalities that we mentioned. And of course, we have more and specific experience in particularly the advanced grades of a lot of the gastrointestinal disorders. So certainly we work with primary physicians as well, and they are very capable in handling a lot of gastrointestinal disorders. But at a certain point, particularly when you need procedural intervention, you do have to see a gastroenterologist.
Common conditions, I think, would be anybody with difficulty swallowing, pain when they swallow, acid reflux, heartburn, abdominal pain where they're not able to figure out why they're having abdominal pain, or they could require procedures to figure out why they're having abdominal pain. If they have jaundice, if they have any changes in their bowel habits. We do have newer medications for constipation now. So if somebody has refractory constipation where they've tried medications with their primary care physician and they're not helping, we have newer medications for that. Unexplained diarrhea. We have, of course, screening for colorectal cancer. Any high-risk family history of GI cancers.
Gotcha.
Just to come and discuss with us and see if they need any screening for any of the different GI cancers. So there's different reasons. Obviously, primary care physicians are usually the first step where patients would go to. But if the first line of treatment has failed and they have any of these symptoms, then I think coming to a GI physician would be a good option.
So let's talk about March as a month, because it becomes Colon Cancer Awareness Month, and I think it's very important for us to continue to spread the word about this as an awareness month. And so the statistics on colon cancer, I think it's important for us to make sure that we're familiar with this when we talk about rates continuing to go up. Colon cancer continues to be a killer. a killer in America, unfortunately, and the lifetime risk for people developing colorectal cancer, 1 in 23 for men, lifetime risk, and 1 in 25 for women. That's not low. That's pretty high. And so I think we need to continue to keep that importance going on. Why else is it important for us to continue to be aware of this important piece of the puzzle?
Yes, so colon cancer is not only in the United States but worldwide one of the largest cancer killer. It's one of the most common cancers in men and women both. We're going to have about 150,000 cases every year, little over that, and about little over 50,000 deaths from colon cancer.
Oh my goodness.
So that's very big number. I think in GI world, only thing that matches is pancreas cancer in terms of mortality. But fortunately, we have a screening program for colon cancer, which gives us an opportunity to prevent these cancers. So that's really great, and I think this is the right time to talk about colon cancer. So sure, I mean.
Well, let's talk about the symptoms.
Let's talk about there's so many aspects of colon cancer is screening, diagnosis, and then further treatment management. We are not involved too much in the treatment part, but post-treatment surveillance.
Yeah.
So these are the main areas that we usually think colon cancer about.
Yeah.
So screening would be big, and that's one of the reasons why patients see us. And then there are certain symptoms that can point towards colon cancer, and that becomes more like diagnostic evaluation.
Yeah. The unfortunate part about colon cancer in its early stages, at least, is a lot of patients do not have any symptoms. So they do not know that they have a mass in their body. And colon cancer, in the initial phases where it is very treatable, does not have symptoms. That's why you need to do a screening colonoscopy even in patients who do not have any symptoms.
Right.
The second important thing is when we do screening colonoscopies, we don't always look for a cancer. We also look for pre-cancer lesions, which are called polyps, that we cut out, which prevents colon cancer in the future. So, looking at the stats, we've seen that the colon cancer risks have decreased in older population, and the reason is because of increased screening. The rates have gone up in the younger population right now. And that's why we need to screen more and more people, and they have cut down the age for starting when to screen for colorectal cancer. But
yes, they have.
Yeah.
Yes, they have.
So the important thing is not just to find cancer, and we don't find cancer all the time, but we find precancer lesions and we remove them so that we prevent colon cancer, and that's why colon cancer rates will go down hopefully in the future if we can remove these lesions.
Which is an ideal situation that you're looking for, right? You want to catch these lesions before they turn into cancer and before you have to deal with more invasive therapies and sort of the morbidity that's related to it. Colon cancer in my mind is a little bit special in that it is very common, right? Third most common, but it's largely preventable, with screening modalities. Pancreatic cancer, as you mentioned, they tend to just creep up when it's very late in the game, and it's a very sad and unfortunate situation. But in my mind, when anyone gets colon cancer, it's extra sad because it really theoretically could have been prevented with proper screening.
And so let's talk about colonoscopies. Let's talk about screening, because we want to, I think in medicine, our goal as healthcare providers is to prevent disease. I think an ounce of prevention is worth a pound of cure. I think that will always be the case. So what are we, who should get, I guess the first question is who's getting colonoscopies? What has changed about the screening, and who should be going out to get colonoscopies?
So people who need colonoscopy, or in broader sense, we talk about colon cancer screening. There are different ways to screen. Colonoscopy is one of those, and the most effective way to screen for colon cancer. Current guidelines recommend everybody at the age of 45 and above should undergo screening for colorectal cancer. That applies to what we call average risk population, which means there's no family history or there are no other diseases that increase the risk of colon cancer. Uh, People who have family history, they may have to start earlier at age 40 or 10 years before the family member who was diagnosed with colon cancer,
Gotcha.
whatever age they were diagnosed with. Then there are certain other people with a history of inflammatory bowel disease like ulcerative colitis or Crohn's disease. They may need to start earlier because the risk of cancer is higher in that population. And there are certain genetic diseases that predispose to colon cancer as well. I'm not going to go into all the details, but these are the common categories that have to go for the colonoscopy or other modalities. It's very important to understand one difference. If somebody already has some risk factor for colorectal cancer, they don't fall into average risk category. And for those people, colonoscopy is recommended, not other modalities of screening.
Gotcha.
For average risk patients, colonoscopy still is the gold standard and the best modality, but there are other options like a stool test, and there's a CT scan option as well called CT coronography.
Okay.
But those are also other options and modalities of screening.
Yeah.
The other important thing for other modalities of screening is if they end up being positive, the patient would still require a colonoscopy
Yep.
to find out what is going on.
Okay.
So if a stool test or a CT colonoscopy ends up being positive, you still need a colonoscopy to go in and see why it was positive.
Gotcha. So that's important to know, because if let's say I'm average risk, but I don't want to have a colonoscopy, there are other options for me
Yes.
that if they're negative, I'm okay. Of course, after conversations with you all.
Yeah.
But then that's the conversation we would have. So we would start at a step and then see sort of what that step reveals and then go from there. So it's not necessarily colonoscopy or bust. There are options for average risk.
That's a great point that you brought up. So when a patient or somebody says, I don't want colonoscopy, I think we should not just stop there. We should ask, okay, why you don't want colonoscopy? There are sometimes people have fears that are not really a big factor. Sometimes they're afraid of just maybe
The unknown,
anesthesia,
yeah.
or they heard a story that one of my friends or somebody had a poor outcome or bad complication from colonoscopy. And actually, those are the patients we would love to see them in the office to go over all the different options for screening. And in my personal experience, a lot of those patients actually finally end up choosing colonoscopy, which I personally prefer is the best way to screen and prevent colon cancer. Because in one procedure, we detect those precancerous lesions and we remove them. And if somebody has no polyps and no other risk factors, they don't need any screening for 10 years.
Yeah.
Which is great. I mean, you know, and this is where we talk about the patient experience, which is very important, and that conversation between the patient and their physician.
Yeah. It's a very safe procedure.
Yeah.
Lots of studies have been done. Of course, insurance companies approve of it, so we know that it is helpful.
Yeah.
Most of the side effects related to colonoscopy have all been found to be less than 1%. So, or even less than that.
Yeah.
So it's a safe procedure. Complication rate is very low, and the advantage or the outcome that we can actually the things that we can detect out of a colonoscopy are life-saving, and that's why we recommend it.
Absolutely. And so, you know, clearly March Colon Cancer Awareness Month. Let's get out to screen. Let's contact our GI team. Before we wrap up, let's look to the future. What are you all excited about in the future of GI?
I mean, I think just like in a broader sense in medicine, the need for gastrointestinal illnesses are going up, right? So we mentioned colon cancer extensively, particularly in young people. We know that that's going up. Now we have a much bigger pocket of people we need to take care of. So if people from 45 to 49, if they're appropriately coming for screening, there's just a much bigger need there. So we are, excited about being prepared to sort of handle that burden and addressing that need. We as a department are growing, adding more capabilities, more personnel. So that's really what I'm most excited about.
Wonderful.
I think for me, working at a community center, the most important thing is that we should be able to reach every single person in the community. We should be easily accessible. We should be, if they need us, at least somebody in the team should be available, and they should not have to wait a really long time to see a GI doctor. A lot of times I hear, oh, my GI complaint even got better by the time I got to see the GI doctor. So I think it'll be nice if we are easily accessible. I always say that if, one personality is not for you, then there's multiple people in the team. So if one person, you're not having a great relationship with one person because of whatever issues, you can always see somebody else in the team. We have people who speak multiple languages from different backgrounds.
Yeah.
So we hope that patients are able to find at least one person in our large team, which is growing, that they feel comfortable with and can easily approach.
Excellent, excellent.
I'm excited for the future of our department. I think we are growing, we're doing great. We are offering most of the GI services that we know of. We can take care of most of the common GI problems and even if very complicated ones. Like Dr. Wander is our advanced therapeutic endoscopist. We perform endoscopic ultrasound, advanced biliary diseases, both cancer and non-cancer. If you have a stone that's stuck in the bile duct, yes, we can take care of it. If there's a cancer, we diagnose and we stage. Regarding colonoscopy, it's a colorectal cancer month, awareness month. So no matter what kind of polyp is there in the colon, we all take it out. And we using cutting edge technology, the most latest ones available. So I'm really excited about all these things we do here. It's great.
Well, it's wonderful. I mean, I think it is such a great service we continue to provide to the community. A growing team, a dynamic team, and one that we're really proud of. And thank you all for what you're able to bring to St. Mary's and to the patients of the Waterbury community. Thank you all for joining us again today, and we look forward to seeing you all at our next Facebook Focus. Thank you.